What we've seen with minimal residual disease or MRD determination in CLL is things have kind of shifted back and forth. So when we were using chemoimmunotherapy, it was very clear that MRD negativity mattered in terms of response duration. Then the paradigm has shifted to using BTK inhibitors where very few patients attain MRD negativity, and it also doesn't seem to matter if patients attain MRD negativity. They're going to do well regardless of whether they achieve that very, very deep response. Now we're using venetoclax, so an inhibitor of BCL2, which actually has the capability of producing minimal residual disease negative responses. And we're seeing again that patients who are MRD negative at the end of therapy do better overall than those that remain MRD positive. And actually in follow-up from the Murano study, and as well looking at some of the initial data from the German CLL14 study in frontline disease, it looks like patients who have undetectable MRD have the longest time of remission off drug. And then you have those patients with intermediate MRD that do tend to relapse, but it tends to be a little bit later. Patients who have high MRD, so like 1% remaining at the end of therapy, they tend to relapse very quickly. So still right now, MRD determination is something that is used in clinical trials and really isn't a part of standard evaluation of CLL patients, but it might become so in the future.